I want to allow some time for some questions. So let's take some questions from our on-site audience. We have a runner with a microphone. If you could just see this person here, and we'll get started. Oh, and please identify yourself.
Robert Lissack, Wayne State University in Detroit. For Dr. Zamboni, I would point out that extravasation of red cells is not a hallmark of the MS lesion at all. Not at all. I would also point out that you can get fibrin in an autoimmune model. Goes back to the 60s, Phil Patterson and other work by Seymour Levine. And simply the inflammatory mediators released by inflammatory cells are quite capable of upregulating factors like VEGF, thrombospondin, and other related things that can cause local fibrin deposition. So I think that one of your biggest problems is the pathology doesn't match this. And the iron deposition is, as you know, nonspecific, is seen in Parkinson's, Alzheimer's, and is actually in normals as they age, and most often in the deep gray structures where you've seen it. So I think you've got a major disconnect with the pathology if you're counting on red cells and fibrin as showing that this is a vascular disease. Just a comment, not a question.
Okay, I want to give him a chance to respond.
Oh, thank you. Thank you, because your comment may permit you to explain some things. What's the origin of fibrin? In the blood. If you have venous hypertension, you have a tight junction in several models, especially in models of pulmonary hypertension made by West, that indicate that you have tight junction enlarged and macromolecules, including fibrin, that pass through the endothelial cells. This is very important because our data show that we have hypertension, and so tight junctions are dilated, and you have extravasation of macromolecules. Additionally, when you have no venous hypertension, but simply impaired venous drainage in the main outflow route, you have diapedesis at the level of microcirculation. And this is particularly evident in the paper on MS, in which the pathologist take the opportunity to investigate a recent plaque, an active plaque, not an old plaque with remodeling in which we lose the trace of a process. There are papers from Adams in London that clearly demonstrate this in a fantastic collection of people who died for car accident or something like this, in which if you look at the active lesion, you find strong extravasation. And if you use now SWI facility, you may easily see that despite the difference in iron deposition in Alzheimer's disease or in Parkinson's disease, the iron encircles the vein. But in Parkinson, you do not find this finding. And also in Alzheimer's, because you have amyloid deposition in the media of the artery. It's a completely different process. And also the origin of that iron is completely different.
But my point was that you can produce, with a pure autoimmune process, the fibrin with absolutely no evidence of venous hypertension. And that the fibrin is described in lesions where there is no evidence of red cell. And we know when you open the blood-brain barrier that indeed molecules that are macro will go out. You get diapedesis without any venous hypertension through the action of lymphocytes and things like proteases. So your evidence is not that strong.
Sure. I just want to, we have actually a lot of questions to get through, so I want to make sure the dialogue is available for everyone, including accessible for the public. So I'd like to take a question now from the press.
Yes, hi. Ava Stavro from CTV. I wonder if it's possible for either Dr. Zivadinov or Dr. Zamboni to summarize the findings presented today in lay language when you were looking at iron deposits and the cerebral spinal flow. What do those studies presented today add to the understanding? And then I have follow-up if I'm allowed after.
I mean, I can comment on the SWI study, and Dr. Zamboni can comment on his hypoperfusion study. So clearly our attempt was very simple in a very small pilot study to look whether there is a correlation between the amount of iron we see in the certain structures of the brain that we believe are important for iron deposition. And maybe somebody, I think Dr. Miller mentioned before, iron is storing, and not just in MS patients, but in Alzheimer, in Parkinson, and in normal people. My personal interest in this new type of research is really beyond MS, because I would like to understand the venous function of the central nervous system in relation to aging, in relation to number of neurodegenerative diseases. And my research on iron might be very helpful. Now, one of the principal reasons why the iron is building in a certain structures, nobody knows really the answer, but it seems to be that the highest concentration of the ferritin receptors is physiologically present in those structures. And so where there is excessive iron, where there it's a primary, secondary phenomenon or result of, just mitochondria dysfunction and oxidative stress, the iron is building in those structures. So what we showed this morning is that there are certain pathways actually where the iron is building. And there are one important pathway is in the thalamus, and in particular in a region called pulvinar nucleus of thalamus that until now really was not investigated in MS by the pure reason that you can't see the pulvinar nucleus of thalamus. Very hardly you can see, if not on the SWI sequence, which is like 100 times more sensitive for seeing iron than other techniques. And our region number 1 to be investigated in the future studies will be pulvinar nucleus of thalamus. I have now several data sets that are pretty much showing very similar thing as in this first pilot study. And we need to understand what is the connection of this build-up in the thalamus with disability, lesions, and start of the disease. To make a parallelism to what is going in a conventional MRI research, if you have been yesterday on MRI imaging number 1 presentation of, I think, 9 papers, 6 or 7 have been on the thalamic and deep gray matter atrophy in MS. So we need to understand whether the deep gray matter atrophy in MS is a result of the iron deposition concentration and toxic effects.
May I just ask a follow-up? It has to do with the 500. You mentioned testing difficulties. What did that mean, and could that affect the prevalence rates that you've discovered as opposed to some of the other centers?
Thank you for the opportunity for asking this and answering this question, because this is something that clearly we did not speak about until now and will be in our clearly peer-reviewed paper when will be published. But we believe strongly that the type of the machine you are using is very important for determining certain structures. The deep cerebral structures are very difficult to determine, if not with some specific technology that Dr. Zamboni actually developed and is now commercializing through a commercial company. And we believe that this is one of the reasons why our prevalence in this criteria was definitely lower than in Dr. Zamboni work. We have some experience by using this new technology that has been developed in the meantime, and we see substantially different results. I also want to point out that the training and the reproducibility of scan, rescan tests in Doppler will be essential, because that definitely may alter the prevalence of the disease. And that's why I strongly believe that only multi-tests will be able to show whether there is certain confidence that diagnosis is met.